Good afternoon, everyone. Thank you for coming to our session. I am Diamond Goodwin. This is Dr. Brittany Boyd.
Good afternoon.
And we are going to introduce ourselves. We're going to be talking about your pelvic floor and more. This is going to be a conversation and discussion with Dr. Boyd and I about fibroids, incontinence, and prolapse. So Dr. Brittany Boyd, she went to Stanford University, medical school here at UCLA. We both shared the experience of doing our OBGYN residency at the University of California, San Francisco, UCSF. She went on to do a fellowship at Irvine, UC Irvine, in urogynecology, which she will explain, and pelvic reconstructive medicine. And now she works at Cedars-Sinai. We both work at Cedars-Sinai here in LA. And there's me. I went to Spelman College, went to Meharry Medical College. Spelmanite? Okay. Meharry Medical College in Nashville, Tennessee. Again, we both went to UCSF for residency. And then I went to University of North Carolina, Chapel Hill for my fellowship. And again, here at Cedars, back home in the city. All right, so I'm gonna start my portion of the talk by discussing fibroids. And I wanted to sort of take us through what we're even talking about. What organ are we referring to, and where do fibroids grow? So this is a picture of the uterus. Here we have the uterine tissue. This is called the cavity or the endometrium. These are the ovaries that flank the uterus and the fallopian tubes. Here we have our cervix and the vagina. So the fallopian tubes are where sperm and egg meet before they travel to the uterus to implant for a pregnancy. And the ovaries secrete estrogen and progesterone, which are our female hormones. Sorry, Britt, thanks. All right, so this is a photo. If we slice somebody in half and we look from the side, we don't slice people in half usually, but if you like mentally imagine that we divide a person in half, we look from the side, the person is facing this way with their back this way, their head's at the top of the screen and their feet are at the bottom. So this is to show you the relationship of the pelvic organs, okay? So we have the pelvic bone, which is this white structure, the bladder, and sandwiched between the bladder and the colon is the uterus, right? So when people are pregnant, they have to urinate frequently because the baby growing in the uterus is pushing on the bladder, right? And Dr. Boyd will talk a little bit about when we lose urine or leak urine, why that might happen in relationship to the uterus. Okay? Any questions about that? Okay, next slide. All right, so now we have fibroids. So there's a lot to know about fibroids, and unfortunately, not a lot is discussed. 80% of us who have a uterus may be afflicted by or suffer from fibroids, okay? Half of that number actually have symptoms. So what's the number one symptom of fibroids, if you could guess? Heavy bleeding, you got it. So fibroids can cause extremely heavy bleeding that can be debilitating and also really impact our health, okay? So amongst the other symptoms of fibroids, we have bleeding, we have bulk or pressure symptoms. So again, constipation in our last slide. If you go back for me. If these big masses are growing in the back of the uterus, they compress on the colon, so it can make the transit of stool more difficult, okay? It can also cause infertility for people who are trying to get pregnant. They may have what we call recurrent miscarriages. And it can also cause like significant disruptions to our quality of life, right? It's something that people usually suffer from silently. So we don't talk about periods in our families. We don't talk about periods in our friendship circles. Usually, if you have heavy bleeding, you think it's normal because you've had it all your life. But it's actually not normal, and it doesn't have to happen. And there's support and help for it. That's where I come in. Oh, wait, I didn't even talk about the slide. So back in our original picture, we had an example of the uterus. So again, this is the vagina. This is the cervix. This is the muscle tissue or the uterine tissue. We have our cavity here where fibroids or babies can grow. And then the tubes are cut off in this photo. But this photo is here to demonstrate the different locations where fibroids can grow. So We have fibroids that can grow sort of squarely in the cavity, okay? We also have fibroids that can grow in the wall of the uterus, either completely in the uterus itself or impacting or pushing on the cavity, or sort of growing towards the outside of the uterus. This is an example on this side of what's called a pedunculated fibroid, which is attached by a stalk, okay? And in my next slide, I'm gonna talk a little bit about how we address each of those. Just kidding, I'm gonna talk about how we diagnose them. All right, so in addition to the symptoms that I mentioned, anemia, heavy bleeding, infertility, pressure, pain, people might get an ultrasound because you went to your annual health visit and you complained of some pressure or pain, okay? And the ultrasound photo at the top is an example of a fibroid, which might be a little difficult to see with the light. Sarah, do you think you can, I don't know if the lights are easy to work, but maybe we can dim them a little bit? Maybe not, it's okay. So anyway, we get an ultrasound, and the purpose of this slide is to show sort of at the top, you see shades of gray, and it looks like there may be a structure there. But in an MRI, which is a better imaging study to detect where the fibroids are, how many fibroids we have, and where they might be located and what kind of surgeries might be necessary, MRI is really important. And so a lot of times doctors may stop at the ultrasound point. But in fact, MRI really is helpful to better characterize our fibroids. Okay?
It's thinking, sorry.
Yeah, it's all good. So when we talk about treatment, treatment is really related to and focused on what is important and what is happening with the person that's coming to see you. So treatment may look like just managing your symptoms with medications. Treatment may also look like managing symptoms with surgery. And sometimes we don't have to do anything depending on how large or small the fibroids may be, okay? But when we are able to intervene, the treatments and the work that I do is in minimally invasive surgery. So what is that? That's basically, I think we all have heard of people getting surgery for fibroids, and you hear this C-section cut, right? Like everybody has heard, oh, I'm getting my fibroids out, and so they're gonna make a big cut. Well, the training that I did allowed me to take these fibroids out through smaller incisions. So I make incisions that are about the width of a fingernail. I blow the belly up with gas. You're very much asleep. I tilt the person back on an operating table, which allows all those intestines that are in the pelvis to move out of the pelvis. And then I get to do my work on the uterus, okay? And that's called minimally invasive surgery. Now, all of us who trained in OBGYN may have some experience with doing minimally invasive surgery. But I think what is true that's important to know when you are advocating for yourself and seeing doctors is that not all providers, even though they do that surgery, necessarily have the advanced training to perform minimally invasive surgery. So sometimes when doctors make recommendations around what kind of surgery that you need to have, it might be limited to what they are able to do. That is not wrong. Doctors should do what they're able to do, right? But I think when we are talking about advocating for ourselves and getting the best quality care, sometimes asking the question of, is this procedure done any other way, right, is an important question that might be able to have your doctor say, well, some people might do whatever, and you can go on and do that research yourself or perhaps ask for a referral to a specialist who might do more of those types of surgeries. Does that make sense? Okay. So I think it's just important to know, we're not moving.
The internet is
okay.
Disconnected, sorry.
That's okay. I think it's just important to know that when we are talking about treatment for our conditions like fibroids, number one, you know what you're dealing with. Number two, you know all of your options. And number three, you know how to sort of ask questions of your doctor or your provider that allow you to get the best care, okay? In our next slide, we sort of talk about, in the next slide, it's not working because of our internet delay, but that's okay. I want to pause, I want to make sure right now if we have any questions, I'm happy to answer those. And then I'll keep talking about the treatment options and whatever else we need to discuss, we will from our questions. Go ahead. Good question. The question is there a procedure where there is no cutting? So one slide ago, the fibroid that I pointed out that was sort of squarely in the cavity of the uterus, that one can be addressed without any cutting. So if you think about it, I usually try to describe it as like a light bulb sitting in a mixing bowl, right? Squarely in the center of a mixing bowl. If you cut a hole, which would be the equivalent of our vagina, in the bottom of that mixing bowl, you can access the inside of the light bulb through that orifice, if you will, right? That is the only type of fibroid that we can safely get to through a non-invasive, no incision type surgery, okay? If the fibroids are similar to the ones that I showed that are sort of growing into the muscle of the uterus or growing outside of the uterus, that's just simply not accessible through that one incisionless surgery, okay? And so a lot of times, oh great, this is exactly what you were just asking. So this procedure is called a hysteroscopy, okay? Hystero is uterus, oscopy is like a scope or camera, okay? And that camera goes inside of the uterus, and we can shave down aspects of the fibroids that might be affecting the uterus, okay? This procedure is laparoscopy. That's those small incisions. The darker pink is air in the belly, and the light is focused on the pelvic organs or the uterus, okay? And that's how we take out a lot of those big fibroids that can't come out any other way except the large incision or the minimally invasive surgery I'm discussing, okay? All right, that was a good question. Any other questions? I saw in the back, here, and here. Yes. Yeah, that's a good one. So the question is, where is the uterine artery embolization come into all of this? Is that correct? Is that the question? Okay. So back to our anatomy slide. Thank you, Dr. Boyd. What's my time?
I don't know.
Phone is
you have time.
Okay.
It's 2:12. You have time.
Okay.
Go ahead.
So the uterus is supplied by the uterine artery, okay? The uterine artery is the main vessel that gives the uterus blood. When one treatment option that is it's a procedure but not a major surgery, is to block the blood flow to the uterus, which decreases the size of both the uterus and the fibroids, okay? And that is done through a procedure where they tunnel through a large vessel in the groin, and they get through to, it's not gynecologists that do that, the radiologists do that, and they block the blood flow to the uterus so that over time the uterus shrinks. The thing about that procedure is that it is not always completely effective. So the goal would be to decrease bleeding and decrease the bulk or size of the fibroids. But if we are further away from menopause, when our period should stop, you may have a recurrence of bleeding if you're like in your 30s and you have this procedure versus if you're 49 or 50. Does that make sense? Okay. I'm coming to you, and then one hand was over here.
Does the strength of the pelvic floor have any relationship to the creation of fibroids? Like if a woman has had 2 or 3, 4, 5 children, her pelvic floor is weaker. If a woman has only had 1 child and is overweight or does not exercise or whatever, does the strength of the pelvic floor influence the creation of fibroids?
The question is, does the strength of the pelvic floor influence the creation of fibroids, okay? And then you gave some great examples of how carrying a pregnancy, carrying more weight in our bellies might also contribute to either the development or the pressure on the pelvic floor. Okay, so the pelvic floor is basically like a basket of woven muscles. Where it would be, it's not on this slide, but where it is here. So it's like this canal is coming through and it's disrupting where it would otherwise be. But it's sort of this basket of muscles that are kind of like a girdle suspending all those organs in the pelvis, okay? And so if you have fibroids, that is going to add to the weight in your pelvis that's going to push on your pelvic floor, which they're muscles. They can only get so strong. So if the fibroids are really heavy, they can push on your pelvic floor and cause urinary leakage, incontinence, right? And they can also cause bulge symptoms, okay? So yes, the fibroids contribute to the function of the pelvic floor, but the pelvic floor doesn't necessarily contribute to the development of fibroids. Yeah. I think I saw one here, and then I have. Good question. So 1 in 2,000 people may have a cancer within a fibroid, but by and large, fibroids are benign. Right behind you. I got two hands. One, two, three is what I saw.
So my daughter's urine was covered with about 90% fibroids, and she had them removed, and they quickly started growing back. How do you prevent that from happening? Now, the one procedure you said by stopping the blood flow seems plausible, but so I have two questions. What about if you want to get pregnant? And then two, once you have them removed, how do you prevent them from coming back?
Yeah, so I'm sorry about that with your daughter. And I think I'll try to answer that broadly so that we can all try to benefit from that. Those are really good questions. So one, treatment starts and ends with the person in front of you from a doctor's perspective. If the person is interested in having children, you have to decide what treatment options are, like would allow for that to be true in the future. Fibroids grow back after treatment at a rate of 35%, right? So when we do these surgeries, they're not curative. We're not really curing the issue. They grow back. And so when you are in partnership with a doctor, you're trying to make your plan and your treatment options that align with your goals. So you time your surgery or your intervention in a way that allows you an interval of time, if you're trying to get pregnant, to take that time once the fibroids have been removed, you let the uterus heal, you go about trying to get pregnant, and then you deal with the uterus after. Sometimes these things just don't leave us alone, and the end point is always hysterectomy if we want it to be. But decreasing the blood flow to the uterus when we haven't yet had children is not the best option. It is an option if you just want to address your bleeding and your goal of future fertility is sort of a secondary goal. But it's not recommended for people whose primary goal is to eventually become pregnant.
So do you compromise your ability to get pregnant by having these fibroids removed?
Do you compromise your ability to get pregnant if you have the fibroids removed? There are two, and there's kind of a double-edged sword there, right? Having them can lead to more miscarriages. Having them removed does have impacts on pregnancy or has an impact on pregnancy, but oftentimes it needs to happen so that a safe and healthy pregnancy can occur, okay? I think I have time for these two, and then we'll move on to Dr. Boyd's portion. Yes, ma'am.
Do these fibroids ever disappear, like after menopause? Do they go away?
I really wish they did. They shrink a little bit. They shrink, but there's very minimal shrinkage. The reason why is because estrogen and progesterone, which are flowing while we're still having a period, that stops when we're in menopause. And so yes, they shrink a little bit, but not to zero, which means that they don't go all the way away, but they stop growing.
Would it make sense to have them removed after menopause?
If you're not having symptoms, it's not necessary unless you feel strongly about it. Okay? And last question here.
So, in terms of them growing, what's feeding it? And then the other thing is, when could it be that there could have been a need for pregnancy?
Good question. So two questions here. One, what's feeding the fibroids? What's making them grow? And then number two, is it possible that a pregnancy can sort of turn into a fibroid? For the first question, estrogen and progesterone, which are naturally occurring hormones in our system, feed fibroids. So you can never take a hormone in your life. You can never have any other hormone that you deal with ever and still have growth of fibroids, unfortunately. We also know that hypertension, so uncontrolled hypertension or high blood pressure, can contribute to the growth of fibroids. So having your blood pressure controlled, even if you're not having symptoms, when the doctor recommends getting on a medication, if you have fibroids, you might consider that a benefit of being on medication because it slows down the growth of the fibroids, okay? And then vitamin D exposure. So as Black and brown people, we absorb less vitamin D, and our vitamin D levels tend to be lower. You can go outside for about an hour a day to make up the difference, or you can take vitamin D supplementation, and that has been shown to slow the growth of fibroids. Can a pregnancy turn into a fibroid? It can't. All right, thank you. There's so much to talk about with fibroids. I am available and taking consultations with patients in my office, and I'm happy to see anybody. So I'm going to hand it over to Dr. Boyd, and she will continue with talking about incontinence and pelvic organ prolapse.
Hi, everyone. I'm Brittany Boyd. I'm a urogynecologist, so I usually like to start just by explaining what that is, because most people are like, what are you and what do you do? So as Dr. Goodwin said, we both did OB/GYN training, but then we kind of diverged a bit. So she decided to do more minimally invasive gynecology, getting skills in advanced surgeries, dealing with fibroids and endometriosis, et cetera. But I decided that I wanted to focus more on the pelvic floor in the sense of more bladder and prolapse symptoms. So you can get to my specialty by going through a urology residency or an OB/GYN residency, but in my case, I've just never taken care of men. I've only taken care of women. So the things that I manage are things like incontinence, so stress urinary incontinence, which is when you leak a little bit, when you cough, laugh, sneeze, jump. The other type of incontinence that's very common is urge incontinence. You get the urge to go, now you're rushing to the bathroom, you leak a little bit on the way to the bathroom. Okay, urge incontinence falls under this bigger umbrella term called overactive bladder. Overactive bladder is when we're going to the bathroom frequently throughout the day. We wake up 2 or more times at nighttime. We, again, urge incontinence. So you can have any of those symptoms, and that falls under this category of overactive bladder. And then, of course, it's possible to have a mix where you have some stress incontinence, some urge incontinence. Overflow and functional incontinence are a little less common. Overflow incontinence are for those who have been told that they're not emptying their bladder appropriately, they're retaining urine because their bladder is always full, that when they're up moving around, a little bit is leaking out at a time. Functional incontinence is really just a matter of your ability to get to the bathroom. So, you know, for some of us, if we can't get to the restroom quick enough because we're using a walker or we need help or assistance from family to get there, some people do have incontinence only for that reason. If they could get to the restroom quicker, they wouldn't have any leakage. So the thing that I like to tell patients just in general is that urinary incontinence is very common, but that doesn't mean it's normal. I know a lot of people like to normalize incontinence, saying, oh, well, my mom had it, my friends have it, my sister have it. You know, isn't that normal? I've just been told that that's just a normal part of aging, and that's not necessarily true. Yes, it's common, but not every woman will experience those symptoms. So generally, people end up coming to me when those symptoms are interfering with their quality of life. They're bothered by this. They can't plan their trips. They're worried about being in long car rides. You're driving down the freeway, you know where every single bathroom is on the way to your work or wherever you're going. You know all the spots, all the clean restrooms to stop at. So that can really interfere with your day-to-day. The waking up at nighttime, waking up multiple times at night, not being able to fall back asleep, and then you're just exhausted the next day. So these things aren't normal. And so if that is something that is bothering you, there is definitely treatment to help those symptoms. Of course, the stress urinary incontinence we do tend to experience when we're a bit younger. So most people will say, well, I've had that since I had my child, or, you know, that was like, I've had that for 30 years, or, you know, however old your kids are. And yes, that tends to present itself on the earlier end, and then as we get a bit older, we get more of the urge type, the overactive bladder, the waking up at nighttime. But you can have either types of incontinence really at any age. I see plenty of 20 to 30-year-olds who are waking up several times per night to go to the bathroom, are having leakage. And then I have women that are 80 years old who are mainly having the stress type of the leakage when they cough, laugh, sneeze, or trying to exercise, and they're having to wear pads or diapers because of the leakage. So urinary incontinence, definitely kind of one of the things that I manage frequently in my practice. And if that is something that is bothering you, you should definitely mention it to your primary care doctor, your OB/GYN. If they don't feel comfortable managing it, look for a urogynecologist, okay? We're very comfortable managing these symptoms. All right. Okay, so then the other thing I like to talk about is pelvic organ prolapse. So usually the way I describe this to people is, do you feel a bulge or a ball coming out of the vagina? If you're like, what? Huh? I'm not sure. You probably don't have it, okay? If you have it, you know you have it. You've felt it before. It bothers you. It rubs on your clothes. It really interferes with your day-to-day. But the important thing to know is that there's nothing dangerous about pelvic organ prolapse, okay? Many women have this as well. It's just something that we just don't talk about, okay? My whole practice exists because of incontinence and for prolapse. And of course, there's other things that I manage as well, but very, very common. Because there's nothing dangerous about it, if it doesn't bother you, it doesn't bother me, okay? So there's no reason why you have to seek out treatment. But if it is bothering you, there are things that we can do. So this is a little bit, I'll go through each of these. It's kind of that similar picture, the side view that we were looking at before. So with prolapse, that just means that there's some laxity or relaxation of the walls of the vagina, and that's what you're feeling kind of protruding at the opening. Sometimes the uterus and cervix also starts to fall down. It loses some of its strength and kind of starts to fall down into the vagina as well. So bladder prolapse is really like a layman's term. Your bladder is not falling out of the vagina. That's just not physically possible. It is the skin that overlies the vagina, or overlies the bladder. So it's the vaginal skin under the bladder that is kind of protruding towards the opening that people are feeling. So that's one type. Sometimes people have rectal prolapse, which is basically the wall, the back wall of the vagina that overlies the rectum, and that is what is prolapsing forward. The other one that is common is uterine prolapse. So, you know, when we're young, we have these really strong ligaments in our pelvis, and over time or after pregnancy or after a delivery, that pressure kind of pushes the uterus and cervix down, and sometimes people feel that at the opening of the vagina. Those are probably the three most common types. So what are our risk factors for kind of all these symptoms we've talked about? For urinary incontinence, stress incontinence in particular, your risk factors are having been pregnant before, having had vaginal deliveries, and then just with time, because the sphincter, the muscles that help keep us continent, those start to relax. We don't have as much strength as we get older. Those muscles become a bit weaker. So all of those things can contribute to that. If we gain weight, our symptoms can get worse. If we lose weight, our symptoms can get better. If we have a chronic cough or chronic constipation, anything that's really putting pressure on the pelvic floor can worsen stress incontinence or urge incontinence. In terms of the prolapse, similar things. Having been pregnant before, having had vaginal deliveries, weight gain, chronic constipation, chronic cough, anything that puts pressure on the pelvic floor can make that happen. Now, it's important to know that there are treatment options for all of these symptoms that I've discussed. I don't know if it's worth going into specifics, but for stress urinary incontinence, of course, there's always going to be conservative things that we can do. Stress, remember, is the type where you cough, laugh, sneeze, exercise, you leak a little bit of urine. The treatment options for those include pelvic floor physical therapy, where you're working with a physical therapist. There is a device called a pessary, which is like a little silicone device that goes in the vagina, helps to support the urethra and the bladder. And then, of course, there are surgical procedures that we can do to correct that as well. For urge incontinence, that's different. So these are people who are rushing to the bathroom, leaking on the way, waking up at nighttime, going frequently throughout the day. The treatment options for those include, yes, pelvic floor physical therapy can help those symptoms. We will sometimes prescribe medications. There is something that we do in our clinic. It's called tibial nerve stimulation, which is essentially acupuncture. It's acupuncture of the ankle, weekly sessions for 12 weeks, and people do get benefit from that, about 50 to 60% improvement. And then there are, of course, advanced surgeries. Sometimes we'll do Botox injections into the bladder or even place a little bladder pacemaker. So lots of options to treat these things that maybe if you've mentioned that you've had these symptoms to your primary care doctor or your OB/GYN, they probably don't know of all the options. And so it's important to know that you do not have to live with these symptoms if they are bothering you. And then, of course, with prolapse, similar kind of conservative options, including pelvic floor physical therapy, where you kind of work on the pelvic floor muscles to strengthen those muscles. Some people will get a little bit of regression, like a little bit of the prolapse will go a little bit back inside the vagina. It's unlikely for it to just disappear, but many people can feel better. They feel more supported. The pelvic floor feels stronger, tighter. They don't feel the bothersome symptoms as much. Same thing, there's a little device called a pessary that can go into the vagina to hold up the structures that are kind of falling down. And then, of course, there are surgical procedures that we do to correct that as well. So lots of things that we can offer. Again, very common symptoms that many women experience, but at the end of the day, not normal, and really encourage everyone to seek treatment if it's interfering with your quality of life. Yes, I'll take some questions. Yeah, so a pessary, people kind of describe it like a diaphragm. It's kind of like a silicone device. It's basically like rubber, and it goes into the vagina and basically just holds up the walls. And when it's in place, it's comfortable. You should be able to urinate with it in. You should be able to have regular bowel movements. You really shouldn't notice that it's there. When I teach patients how to use it on their own, they put it in, they leave it in for a week, they take it out, they clean it with soap and water, and then they put it back in. Some people don't feel comfortable doing that themselves, and so they'll come and see me every 3 months, and I will take it out for them, put it back, clean it, take a look inside the vagina, put it back in, and then they come and see me regularly every 3 months or so. The risk of infection is very low with pessaries, so I don't usually expect that. Pessaries, because it's a foreign body in the vagina, can cause some discharge. For many women, that's not bothersome to them. For some, it is, and then we just shorten the interval of how frequently we take it out and clean it. Yeah. The effectiveness? Yeah, so I would say that with pessaries, when we are using it for either stress incontinence or for prolapse, if we find the correct size, people should get resolution of their symptoms. So it's a little bit like trying on a pair of shoes where you come in for a visit, we try on different sizes and styles, and we find one that is going to be comfortable for you, not gonna fall out, and allows, it pushes everything back in, and where you don't feel those prolapse symptoms anymore. So very effective. Most people are fitted with an appropriate size and shape. Occasionally there are some patients where we just never really find one that fits or feels comfortable to the patient. But I always think it's worth trying. You know, conservative options are never a bad idea. You always have the option of surgery later. So there's no reason why you have to jump to a surgical procedure. But pessaries can be very effective. Mm-hmm.
People are always very informative, very educational, necessary.
Mm-hmm.
My argument is, if you're telling us all this and we see all this, and everything on TV talks about the pins and all the pads and all the goodies,
Yeah.
and then you see things on TV about information.
Yeah, that's why we're here.
I mean, I'm just saying,
Yeah.
this should be on TV.
Right.
And not the pad commercial.
Right.
Because
Right.
the pad commercial is making somebody a bunch of money.
Yep.
Where this is gonna help us get better if somebody has these problems.
Agreed. Agreed. Let's go to the back. The woman with all the rings on her hand. Yeah. Okay. Yeah. That's a great question. So actually, prolapse and incontinence can be completely different entities. So just because you have prolapse doesn't mean you're going to have incontinence. And just because you have incontinence, it doesn't mean that's because there's a prolapse. So actually, if you think about it, if there is a prolapse of the wall that sits underneath the bladder and it's kind of dropping down, it's actually kind of putting a little kink in the urethra because everything's falling down. So it's sorry. The urethra is where we urinate from. So the little hole where we urinate from. So if you think about it, that area, that tube where it connects from our bladder to the outside of our body is a little bit kinked. So you actually probably have less leakage than when we go to fix prolapse and we push everything back. Now that tube is really straight and you actually have more leakage. Now, occasionally if people have a very large prolapse of that bladder area, and you're not emptying your bladder well, that could contribute to your urgency. If you're always having urine sitting there and never fully emptying, you're always going to feel like you have to go. So. Mm-hmm. Uh-huh. Yeah. 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 Yes. Good.
Do exercises like Kegels help the prevention or the correction of the prolapse?
Yeah, great question. Sorry, I wasn't repeating everything, so I apologize if you guys couldn't hear some of the questions. She was just asking, do pelvic floor exercises help with prevention? So that's great. Yes. So when I say, pelvic floor physical therapy is an option for these diagnoses, I mean going to a physical therapist who's going to do an internal exam to feel those muscles of the pelvic floor. She's going to make sure you're doing the exercises correctly, that you're sustaining the contractions correctly. You're going to be doing exercises in between your visits, and you're doing that for about 3 months, so 12 weeks of therapy. The reason why I say that is because many women think, oh, well, I've been doing Kegels forever, and it's not helping me. Well, many times women are not doing Kegels right, and so you really do need a provider to kind of tell you that you're doing and activating the correct muscles. We have many studies that show that pelvic floor physical therapy with a therapist alone can improve symptoms by about 50%. So it actually does work. And I am a firm believer that Kegels and pelvic floor physical therapy should really be offered to all women, especially after delivery. That just should be part of our routine standard of care, which we don't always do. But to get people kind of in the regular habit of kind of making sure that those muscles are strong and strengthening those muscles. So yes, it can help with some prevention. That's not the full story because I do think that there are other factors that put us at risk of these symptoms that, doing exercises are not necessarily going to prevent everything from happening. So, yes. Oh, that's nice. Mm-hmm. Yeah, so your question was, what are the different surgeries for prolapse? So they're very specific and individualized. So when you see a urogynecologist, they will do an exam where they're taking measurements to see which type of prolapse you have, because each prolapse gets treated differently. But in general, the different types of surgeries include surgeries that are done through the vagina, fixing just the walls that are prolapsing, or doing a hysterectomy through the vagina and holding up the top of the vagina, Or there are surgeries through the abdomen. So robotic surgeries where we do laparoscopy, as Dr. Goodwin had mentioned previously, small incisions on the belly, where we're using a little piece of mesh to hold up the top of the vagina. So we do vaginal surgeries and we do robotic surgeries, but it's all dependent on your exam with your provider and which compartment or what type of prolapse you actually have. Yeah.
Okay, I think my question is similar to hers, but I'm asking in the reverse. And the question itself can probably be asked or answered by either of you. So the question is, women who have had hysterectomy, women who have had fibroids removed, are they more inclined to have POP and incontinent situations?
Yeah, that's a great question. So I would say that when you have a hysterectomy, you are cutting through, or the surgeon is cutting through some of the ligaments that do help to hold up the uterus. So yes, there is a risk of developing prolapse after a hysterectomy if nothing has been done at the same time to make sure that that doesn't happen in the future, which usually is not being done if you're not having your surgery done by a urogynecologist. I wouldn't say that having a hysterectomy necessarily puts you at more risk for incontinence. People can have those symptoms independently of a hysterectomy or a removal of the uterus. And same with prolapse. Not everyone who has a hysterectomy is going to develop prolapse. Again, I think that there is some other factors, including genetics and whether or not you've had these deliveries before, or you've been pregnant before. There are other factors that play into your risk factors for development of prolapse. Yes. Oh, sorry. Yes. Okay, great.
Okay, so about the uterus, like some people have fertility uterus, does that matter with that? And then also,
Yeah, good. Yeah.
when there is, so like you mentioned the floor, pelvic floor, so I know people use Kegel
Mm-hmm.
balls,
Mm-hmm.
and then oh, the weight. You mentioned the weight. So can you explain those things, all three?
Yeah. So your question was, one, like, how does having a tilted uterus or a uterus that's tilted in a different way contribute? Huh? And then the other one was about the Kegel weights, the Kegel balls. And then your last question was about, yes, weight. Yes, yeah. So in terms of whether or not your uterus is tilted in a certain way, doesn't really play any role in this. That's just a variant of normal. There are some women who have a uterus that's tilted backwards versus forward. That's just a variant of normal. There isn't any data to show that that contributes to incontinence or prolapse. The Kegel weights, it's not something that I'm like often recommending to patients. I know they exist, and there's a lot of like celebrities who are pushing a lot of pelvic floor, paraphernalia. That's not to say that they don't work. It's just more that, I like to recommend things that are standard of care. We have studies to show that they actually help. And I know that pelvic floor physical therapy with a therapist is great and can work. And we do have studies to show that. So I'm not routinely recommending those like Kegel balls. And then weight. Yeah, so I was just mentioning that basically weight gain can make all of these symptoms worse. When you lose weight up to 8% of your body weight, you can significantly reduce your incontinence, so the overactive bladder, the urge incontinence, the stress incontinence, and it's likely to also help with the sensation or how bothered you are by your prolapse. Again, it's unlikely that if you lose weight, the prolapse is just gonna kind of regress and go back into your body, but you may feel less bothered if you have less pressure pushing down on the pelvic floor. Oh, yeah.
For the incontinency, for urgency, and for stress continence.
Mm-hmm.
So I'm hearing that you recommend
Mm-hmm.
and also if you're overweight, weight loss.
Yep.
So those three things, so, after you've done those things, what's the next step? Is there anything else they could do for you?
Definitely, yeah. So we kind of briefly, I briefly touched on that, but what I would say is those things that you mentioned, the physical therapy, Kegel exercises, weight loss, those are conservative options. I would never say that anyone has to stop at that or even really do those if it doesn't work for your lifestyle. I mean, I have some women who come in and say, well, I'm not going to do physical therapy. Like that just seems uncomfortable. I don't want to do that with a therapist, or I don't have time to go in every week. So there's no reason why you have to start there. But I do usually offer all those options to patients. I'm a conservative person, so if it were me, I would start with conservative, and if that didn't get me anywhere, then I move on to something else. Remember I said after physical therapy, stress incontinence and urge incontinence gets treated differently. Urge incontinence gets treated with medication, acupuncture of the ankle, Botox injections into the bladder, or even like a little bladder pacemaker. For stress incontinence, the next two options are either a little pessary, which is that little silicone device that goes in the vagina, or a surgery to help with the leakage when you cough, laugh, sneeze. So the options kind of diverge after the pelvic floor, but they're, again, the ones that you mentioned are the conservative options, and if you've done those or it doesn't work for your lifestyle, there's no reason why you can't jump to something else that sounds more appealing to you.
We have just under 15 minutes left, and so we can take questions about fibroids
Yep.
or incontinence.
Yep.
I think you had a question in purple and then right in front of you.
So I have symptoms of seems like both stress, or I guess like it's a mix.
Mixed,
The urgency, like as soon as I walk into a building, it seems like I gotta go find the bathroom or I'm in the bowl and something I can't hold it. But as I'm going to the bathroom, it's leaking.
Mm-hmm.
And I can't hold it, like it will not stop. I can't stop it. I always gotta wear pads.
Mm-hmm.
It doesn't matter where or what. So I guess it's both. Is my bladder won't stop. I can't control this
Yep.
urine coming out, but also I can't control the urge when I come into a building or
Mm-hmm.
so would I need both treatments or just one? I talked to my gynecologist actually yesterday I talked to my primary care at UCLA. He put me he made a referral for
Urogynecology?
yes.
Yes.
Yes, he did. And then he made a referral for the treatment, the physical therapy,
Mm-hmm.
and for me to go to see the urogynecologist
Yep.
at UCLA to see about. And so that was one of the reasons I came here today.
Yeah.
Because I'm tired of it.
Yeah.
So I think that's probably what they're gonna do. I guess a mix. Is that what it is?
Yeah, well, so just in general, what you're describing, the urge, rushing to the bathroom, you walk into a place, you're like, oh my gosh, I have to go to the bathroom, you leak before you get there. That's called, yep. Yep. So that's called overactive bladder, urge urinary incontinence. From what I heard from you, you're not describing stress incontinence, which again, remember, stress urinary incontinence is where you do a physical activity like cough, laugh, sneeze, exercise, jump. You're doing something that then causes the leak. But if you have urge, you can't hold it, you're rushing to the bathroom, that's called urge urinary incontinence or overactive bladder. So, Jean,
Jean Jack.
well, you guys are both wearing jean jackets, so.
Okay.
Hoop
this
earrings.
behind you. Yes.
Yes.
And then one in front.
So what are the long-term after effects of having a hysterectomy? So I had a partial hysterectomy in my early 40s. What do I have to look forward to, as time goes on, and what is left if you have a partial hysterectomy? Because when I looked at the picture that you have up there, like, where's everything sitting at?
Yeah. That's a good question. So after hysterectomy, so partial is a term that was previously used to describe keeping something other than the uterus. Like, they used to take everything: ovaries, tubes, uterus, cervix, all of it. But when they didn't take everything, they called it a partial. And that means you either have ovaries or you have your cervix, or both. And so in terms of what's happened since then, if you don't have a cervix, you didn't need to get pap smears, didn't need to happen. All you have left are the ovaries. And so your body will hormonally go into menopause around the age 51. The best time to know when we will go into menopause is when our mothers went into menopause. That's around the age we will go into menopause. But the average age in America is 51. So you may still start to feel hot flashes, mood swings, insomnia, brain fog, all the delightful things we have to look forward to in menopause around the age of 51, because your hormones produced by your ovaries are still active because they're still in your body. But in terms of negative side effects or consequences of having a hysterectomy, frankly, there aren't a ton, because once the uterus is, I will say, when we have a hysterectomy, we remove the uterus and we still have our ovaries, you may start to feel those hormonal changes 1 to 2 years sooner than the average age. So 1 to 2 years sooner than 51, okay? But in terms of the risk of prolapse or incontinence, those risks for all of us at baseline, many of us will experience some degree of prolapse in our lifetime, but it might not need intervention, right? So could that be true for you? Yes. But is it definitely going to happen to you because you had a hysterectomy? We can't say that for sure.
But what are the ovaries attached to?
Good question. So the ovaries have an attachment to the body wall, so the abdominal wall, and in the center of our bodies to the uterus. So when you have a hysterectomy, the only thing that is removed is the center connection. So they're still connected to the body wall. And then right in front of you. I got you. Yes, we have cards in the back. Mm-hmm.
I went through chemo and cancer treatment, and then I'm having, like she said, urinating a lot. I went to the gynecologist for my regular treatment, and she said, well, you have fibroids. I had fibroid embolization
Okay.
in 2006.
Okay.
She said the fibroids are back. It's the size of like 3 months. And I'm like, maybe that's pushing on my bladder. I need something else. And she was very dismissive, so I'm glad I'm here because I wanted to get a second opinion, because everything is not related to me.
Yes.
Some things are common sense, you know, and if you don't ask her yourself, she didn't want to, she was like,
Mm-hmm.
and I just didn't feel that was right, and I know it's not just, you know how you know when something is.
Understood. First, I'm going to celebrate your survivorship. Congratulations. And the question was, you have started to have incontinence after some medical treatments, and you are concerned that something is pushing on the pelvic organs and the bladder, and your doctor did something and noticed that you have fibroids. Uh-huh. Yeah.
And I'm like, well, is that kind of pushing, because it's extra weight down here, could that be pushing on my blood to make me go to the bathroom 5 times?
Yeah.
Which I'm not getting my proper sleep, you know, everything is affecting, one thing is affecting another. And she was so dismissive, like it's no big deal.
Yeah. I'm really sorry she was dismissive. That's not fair. You deserve better than that.
First and last time I was.
I got you. Okay, good. The question is, leakage of urine is a symptom of fibroids, but it can also be a symptom that doesn't go away after you address the fibroids, because leakage can be an entirely separate thing. But the job that we have is to start crossing stuff off, right? Like, we have to go down the list and say, okay, well, if you try physical therapy first of all, what's the biggest problem and what's the biggest threat? And we start there. And if it's leakage, you do some physical therapy. If it doesn't get better, we talk about how we can address the fibroids. If we don't find a reasonable option for the fibroids, we can do some things to help with leakage. It's rooted in what is bothering you the most and what is the right treatment for you and the safest thing for you, and then how we can make your life a little better by doing those little interventions.
And I'd also like to add that sometimes patients come to me and they say, well, I have fibroids. Is that the cause? And I go and look at their ultrasound and their fibroids are like itty bitty. They're like, yeah, maybe they have 3 fibroids, but they're a centimeter big. Those are not causing your bladder symptoms. You know, occasionally you'll see, you know, depending on where the location of the fibroid is, if the fibroid is on the part of the uterus that abuts or sits next to the bladder, maybe I could be convinced. But like Dr. Goodwin was saying, I never promise anyone that their bladder symptoms are going to get better after a surgery for fibroids, because we can't guarantee that. It is possible, depending on location and size, that those things could be contributing, but we wouldn't be able to say that for sure because, again, these other symptoms could be happening independently of the fibroids.
I have your hand and then the one behind you.
Okay. It's regarding having a hysterectomy.
Okay.
My mom and I both had full, complete hysterectomies in our 40s. I was never sure if I would do menopause. I don't know that she went through menopause. Because we had full, was there a menopausal period?
Yeah, so the question is, I had a hysterectomy. It was a full hysterectomy. When did I go through menopause? So when you remove the ovaries, that is considered a surgical menopause. So you went into menopause the day you had surgery, if your ovaries were taken out. And it's important to know that if you are younger than 50, your doctor should have a conversation with you about replacing estrogen until the average age of menopause, which is 51. Estrogen has really good benefits for us up until that age. And so if somebody in your life is having a hysterectomy and their ovaries are coming out and they're in their 30s or 40s, and sometimes right before 50, depending on their symptoms, it's important to also have that conversation about hormone replacement.
Yeah, my daughter is 44. She's having perimenopause. Does she have a partial hysterectomy?
Yes. So the standard of care now, we learned in science that when women were getting all of their organs taken out, they were suffering more from heart disease, early onset dementia, and bone loss. Okay? Your risk of that bone loss is higher with being Caucasian, and being underweight. Okay? However, those things were true. And so we stopped doing that. And so now the standard of care is that if you have a hysterectomy, up until the age of 65, you should keep your ovaries, unless there's something wrong with them. Uh-huh.
Okay, I wanted you to address, and what you just said was very vital, very good information. Thank you both. Very, very good information.
You're welcome.
Polycystic ovaries, I want you to address that. And is there ever a time that a person would have polycystic ovaries that become fibroids or become invasive postmenopausal?
Good question. So the question is polycystic ovarian syndrome, which is also called PCOS. I'm sorry, I missed the beginning. I forgot the beginning question, the first question, which was talk about it. I think that was, okay, speak on.
Because you were speaking about fibroids.
Sure,
And you were speaking about incontinence and POP, but I was asking you to
address PCOS.
Yes, address polycystic ovaries, and how does that work in terms of fibroids?
Sure.
Or,
Are they related at all? Yeah.
Is there something connecting?
Yeah.
And then how does that work in post?
Menopause. Great. So fibroids and PCOS are not connected. Fibroids grow from the uterus itself, and PCOS is a condition that's related specifically to the ovaries. Once we reach menopause, the ovaries are no longer active, and so if you had PCOS, you no longer have the symptoms that are caused by PCOS because of menopause. What is PCOS? Polycystic, poly means many, cystic means cysts, ovarian syndrome. So it's a cyst that historically had been described by seeing lots of little cysts on the ovary. Now, every month, we ovulate or release an egg from one side or the other, one ovary or the other when we're having cycles. So we make a little cyst and then it goes away on its own. So having a cyst on an ultrasound, not all cysts are created equal. Many and most are normal or physiologic, but when you have more than 20 cysts on one ovary, you have one criteria for diagnosing PCOS that's sometimes seen on ultrasound. When something is called a syndrome, it means that it has several different manifestations. It's not just one thing. So it doesn't look just like one thing. So the reference to polycystic ovarian syndrome comes from the fact that people can have male pattern hair growth, which means that you have an abundance of hair on your chin, on your chest, on the hair that grows from our pubic hair up to our belly button or between the thighs. That is excess androgen or male hormone that is produced from having PCOS. A lot of times, numerous cysts on the ovaries, male pattern hair growth. Number 3 would be irregularities in our period, which means that you don't have a period altogether, or you skip periods and you have less than like 3 or 4 a year, right? Or you're just not having them at all, which is not good. Everybody should have if you're not on hormones to prevent a cycle or birth control, you should have a period at least every 3 months. If you're not, and you're meaning when you're premenopausal, you haven't hit menopause yet. So you're not having periods, many cysts on the ovaries, male pattern hair growth, and then we can struggle with weight loss and metabolic dysfunction. So glucose intolerance or diabetes, prediabetes, all of those things can be seen with patients who have PCOS. Unfortunately, there's no cure. We just manage the symptoms. Science hasn't figured it out yet. So if it's hair growth, we send you for electrolysis or going to a dermatologist to get the hair addressed. If you're not having periods, we put you on medicine to restore periods or supplements to restore periods. If you're having infertility, which is also a symptom of PCOS, we may send you to the fertility specialist. It's not a condition that necessarily has a next step unless you're bothered by the symptoms or the symptoms are impacting your overall health, such as glucose intolerance. Again, that not having a period and you should be having a period, things like that. All right, and I just want to acknowledge everybody's time. It's 3:01, and so if you have to leave or you need to, you are free to go, but we have about 15 more minutes to answer some more questions. Thank you for your attention. Yes, of course.
Thank you. Thank you.
Yeah, we're still happy to take questions. Yeah.
So based on what you were just saying,
Uh-huh.
my daughter's kind of.
Oh, sorry. 1 second. I'll take you after there was a hand right before you. I apologize. I'll be right back to you. Go ahead. Uh-huh. Ooh. Yeah, so we're at Cedars, and there are so many doctors in LA. I would say that if you're looking for a doctor, first the best place to start is like call your insurance and see who's available, like who you can go to. Oh, if I could recommend somebody else. You're with Providence. Okay. But that's what I'm saying. So like if you have your insurance, you can call and see who's taking patients, and then from there you can decide who's appropriate. And honestly, when you go on to see, it depends on what you need, but you go on and you see if it's surgery that you need, look at the reviews. You'll learn a lot from the reviews. And then I just got back in 2023, and so I'm just making my friends in the city, you know.
When I asked about the surgery, because I had the first treatment, and then they didn't recommend it.
Oh,
That's why.
I see. You're at Providence. Do we know people at Providence?
No.
Cedars.
I'm at Cedars. I mean, I know a lot of urogynecologists, but I don't. I mean, I can talk to you afterwards. I can give you like kind of like a list of names if you're interested. I just don't know what insurance they take, but the urogynecology community is pretty small, so there aren't a lot of us. Yeah.
I wanted to take your question.
Okay, so what we were just talking about, my daughter is the opposite. She has a period sometimes for a whole month where and it gets so bad till she blacks out and everything. And she has been diagnosed with polycystic syndrome. And she's like 30. So she has blackouts
I'm sorry that's happening to her. So the question is that, unlike with PCOS, that description, your loved one is having periods for as long as a month and is having episodes of passing out because of all of this bleeding. So unfortunately, it sounds like she has anemia that is pretty severe, that is a result of that heavy bleeding. And when people are having bleeding that long, something else is usually going on. Either they have, like most commonly, it's fibroids, or something called adenomyosis, which is a different condition that causes irregular bleeding. Or they have something called a coagulopathy, which means like when they cut themselves, they won't stop bleeding. And so those are the possibilities that are the highest on the list. But for most people, it's fibroids. Mm-hmm. That's multifactorial. So that there's a lot of things that contribute to egg count. But typically when we're bleeding that heavily, it's because something is going on with the uterus itself, and less so the hormones. The hormones might be a little wonky, but when you're bleeding that much, something else is going on with the uterus, and that's where I would start, with the uterus itself. Yeah.
There was a question. I think she had her hand up.
Okay, behind you?
In the back.
Okay.
Yeah, yes, you. Yeah.
Hi. Yeah. So the question is, do fibroids reduce in size on their own? And then 2, how do you take care of yourself when you do have fibroids? So generally, fibroids either stay the same size, or they grow just a little bit, or they grow a lot over time. And the best way to know that is to get serial ultrasounds, which means that we get an ultrasound with some time frequency. So if you're not bothered by your fibroids, I would say you should get an ultrasound at least every year to track the size of your fibroids. They don't typically shrink on their own because they're fed by normally occurring hormones in our bodies. So estrogen and progesterone, when we have our normal cycles, that's what feeds the fibroids, and that's why they usually don't shrink on their own. There's a lot of people who are trying to make money off of people wanting to pursue natural routes to cure certain conditions. I am not here to say that those things don't ever work, but I am here to say that I see people on the other side who have tried it and it didn't work. And so I just recommend that if you try something natural, or that's being peddled from the internet, frankly, as natural, that you still collaborate with your doctor to get surveillance of your fibroids to see if it's working. And maybe you shorten your interval to 6 months or, versus a year to see if it's actually helping before you go years without readdressing it. Ways to slow fibroid growth is if you have hypertension, making sure that's well controlled. When fibroids get more blood flow, there's more oxygen delivery and there's more hormone delivery to the tissue, and so they can grow. Vitamin D supplementation can decrease the rate of growth. Those are the things we know for sure. There's some nutritional data that suggests that red meat, soy products, etc., may contribute to fibroid growth, but that data is not certain. It has not been clear that, yes, if you eat this, you're definitely going to have growth of your fibroids. It's just what we call an association. So the way I talk to patients about that is I say, things in moderation make sense. I'm not telling you don't ever eat red meat, but if you can limit it, that's not the only reason why it's beneficial, right? If soy, just don't eat it in excess. Like if you enjoy soy milk in your coffee, have it a couple times a week. That's not going to harm you. But if you're having soy with every beverage at every meal, something may not go so well, right? So everything in moderation. And if you notice that there's a nutritional recommendation around fibroids, try to decrease it, or try ginger. Green tea has been thought to be helpful, but not definite or guaranteed. The things that I know for sure in terms of the data are hypertension and vitamin D. Mm-hmm. Yeah. Mm-hmm.
As far as cycles and menopause, are there preventive measures to help transition?
Yeah. You know what? I think, frankly, if we keep it basic, having conversations is preventative, right? Talking to each other, talking to your family, seeing what's going on in the family as it relates to our female reproductive organs, so that you can get the care that you need, so you can mention to the doctor what runs in your family. So endometriosis runs in families, fibroids run in families. And in terms of cycles, when it's heavy for your mom, she had a hysterectomy when she was really young, yours is really heavy, it's probably because more is going on, right? And a doctor can probably help with that. In terms of the question you had, the age at which we go into menopause can be predicted individually within families by the age that the mother went into menopause, unless, of course, you have a surgery, in which case we won't really know when you would have otherwise gone into menopause. Yeah. Mm-hmm. Sure. Yes, ma'am. Mm-hmm. Pink.
I was seen by my gynecologist a long time ago, because I was having frequent urination. And she examined me and she said, I guess my bladder had dropped. So she said, just do the cake and that kind of thing. Don't worry. I hypertension, so I'm a diuretic. Hydrochloride, thiazide.
Hydrochlorothiazide. Uh-huh. Uh-huh.
And that don't do nothing make it. I mean, it's crazy. So last week, I talked to my doctor and I was telling that, so she reduced or changed the lisinopril, where I was taking 2 lisinopril a day. Now I'm only taking 1 lisinopril. And I don't know what you guys call leakage. I don't leak. I faucet. I just, and it's like, if I stand up, it just,
Yes,
I
ma'am.
pull,
Yeah.
go to the bathroom, urination. And would you recommend, because, you can't tell your doctor nothing to me. I don't want to go back to, well, let's just try therapy. I would like to do something more advanced. When I talked to them about it, but then I was scared I would hear things about the bleach matter,
Mesh.
Mesh.
and they were recalling them and people was having problems. So I don't want to do that because it scared me. So the things that you were talking about with the little rubber cup that you put
The
in,
pessary.
yeah, how do I talk to my doctor into helping me with that?
Yeah, that's when you say, can you refer me to a urogynecologist? Because your provider they don't know everything. That's why we have specialties. But yeah, there are urogynecologists at Kaiser too. I know many of them. So yes, so Kaiser has urogynecology. You can be referred. They have other things to offer you for your symptoms that you're describing. Mm-hmm. Yeah.
Take 2 more questions.
So what if you've gone through menopause and so that means you don't have anything that's feeding fibroids, right? And you still maybe sometimes spot,
Mm.
and after maybe 2 years of going through menopause or something, and then you start spotting fibroids, would that make you spot or?
That's a good question. So the question was, after going into menopause, which is defined by not having a period for a year, if you start spotting, do fibroids cause that? And so the short answer to that question is, if you start spotting, you need to contact your gynecologist and let them know that that has happened, because they would want to see you. The most common reason for people to have any sort of spotting after menopause is that because our uterus is not getting the hormones it used to get, the tissue inside sort of sloughs off and comes out as spotty tissue. But the less common but more scary thing is cancer, right? And so the thing that is required when somebody has spotting, it doesn't mean that you have cancer, But it does mean that the tissue should be tested with something called an endometrial biopsy to make sure that there's not cancer there. And most of the time it isn't, but sometimes, and we want to make sure, because uterine cancer is treatable, but black women are dying from it, right? So there's a discrepancy there, and I think it's just knowledge that bleeding after menopause is not normal, and that we have tests to help figure out if it's cancerous or if it's not, okay?
What if your body is still feeling like you're having a period?
Yeah, some of those symptoms can be related to menopause, which is a doozy. And so even more of a reason to see a gynecologist to help out with we do have ways to make that better. They do involve medications. Sometimes that's hormones, sometimes it's not. And there are some natural supplements or activities like acupuncture and just like behavioral changes that can be recommended to help. But that can sometimes be related to menopause. Yeah. Last question. Yeah. Hi.
Can you have fibroids that are too big for this small cut surgery?
You can. So the type of surgeries that I do, again, are minimally invasive, but size, number, and location are the determinants for what route we take, whether I can safely take a minimally invasive approach or if I have to do a cut in the bikini line. That wouldn't be as big as a C-section cut, but nevertheless, it's one incision in the low abdomen. So the biggest risk of fibroid surgery is bleeding. And so I have to be sure that I can move fast enough and safely enough to get the fibroids out in order to prevent excessive blood loss. And if I cannot guarantee that, then my recommendation is going to be for open surgery or an abdominal surgery. If I can do it laparoscopically, I will always go that route, but I will not compromise safety. That's the way I approach it. All right.